Diverticula of the pharynx, esophagus, stomach, and small intestine carry B. Dunbar, D. Rohangiarija 26. Diverticula are outpouchings from tubular structures. True diverticula involve all layers of the intestinal wall, whereas false diverticula are due to herniation of mucosa and submucosa through the muscular wall. Many diverticula contain attenuated portions of the muscular wall of the intestine, and hence may be difficult to define as true or false. True diverticula are often assumed to be congenital lesions, and false diverticula are assumed to be acquired, but this is not always the case. Some authors reserve the terms false diverticula or pseudo-diverticula for diverticula caused by an inflammatory process. This chapter addresses diverticula of all parts of the GI tract, with the exception of mecal diverticulum and colonic diverticula, which are covered in chapters 98 and 121. Zinker diverticula. Ludlow first described a patient with a hypopharyngeal diverticulum in 1767, and in 1877 Zinker and von Ziemssen reported 23 such patients. 1,2 Epidemiology, etiology, and pathophysiology. The prevalence of Zinker diverticula has been estimated to be between 0.1% and 0.01%. Patients generally present in the 7th or 8th decade of life. Twice as many men as women develop Zinker diverticula. 3,4 Zinker diverticula are acquired. They develop when abnormally high pressures occur during swallowing, leading to mucosa that protrudes through an area of anatomic weakness in the pharynx known as Killian triangle, see chapter 43. Killian triangle is located posteriorly where the transverse fibers of the cricopharyngeus muscle of the upper esophageal sphincter, UES, intersect with the oblique fibers of the inferior pharyngeal constrictor muscle. The size of this area of weakness varies among individuals. Relatively large defects may predispose to the development of Zinker diverticula. 4 With a Zinker diverticulum, opening of the UES is impaired, generating high pressures with swallowing. In patients with Zinker diverticula, several pathophysiologic changes have been documented in the cricopharyngeus, including inflammation and fibrosis leading to poor compliance and abnormal relaxation of the cricopharyngeus. 5,6 These changes lead to a reduction in compliance and decreased opening of the UES. 3 Other types of diverticula similar in appearance to Zinker diverticula have been reported as a complication of anterior cervical spine surgery. 7,8 Killian-Jamieson diverticula are seen just below the cricopharyngeus and have a similar presentation to Zinker diverticula. 9 Clinical features and diagnosis. Common presenting symptoms are listed in box 26.1, with dysphagia and regurgitation as the most common complaints. Patients with small diverticula may be asymptomatic. In some patients, Boy's sign, a palpable nodule or swelling on the left anterior neck that may gurgle on palpation, can be found. 10 Zinker diverticulum can be suspected from a careful history. Barium swallow is the most useful diagnostic study. The radiologist should be alerted in advance so that proper views are taken. Fig 26.1b, see also chapter 44. Small diverticula may be seen only transiently. Barium swallow in the lateral view using video fluoroscopy is helpful for detecting small diverticula. The opening of a large Zinker diverticulum often becomes aligned with the axis of the esophagus. Oral contrast will preferentially fill the diverticulum and empty slowly from it. Large diverticula are therefore often obvious, even on delayed images. Zinker diverticula more often on the left side of the neck. Zinker diverticula may be discovered incidentally during barium swallow or upper endoscopy, see Fig 26.1a. Carried out for investigation of unrelated problems. When evaluating patients with symptoms suspicious for the presence of a Zinker diverticulum, consider obtaining a barium swallow prior to endoscopic evaluation. During endoscopy, Zinker diverticulum should be suspected if, on entering the pharynx, the UES cannot be located. In such cases, the endoscopy should be stopped, and the patient sent for a barium study. Complications. Squamous cell cancer may develop in Zinker diverticula. The estimated incidence is 0.4% to 1.5%. 3,11 If myotomy without diverticulectomy is planned, it is prudent to carefully inspect the lining of the diverticulum for any evidence of cancer. Bleeding may occur from ulcerated Zinker diverticula. 12 Aspiration of retained food contents may lead to aspiration pneumonia. 13,14 Medications may become lodged in Zinker diverticula and can cause ulceration and pain, as well as decreased medication effectiveness. 15,16 Because a Zinker diverticulum is occasionally palpable on physical exam, it can be difficult to distinguish from a large thyroid nodule. An accumulation of radioactive iodine tracer in a Zinker diverticulum has been reported to lead to erroneous diagnosis of metastatic thyroid cancer. 17 The video capsules used for capsule endoscopy may also become lodged in Zinker diverticula and should be delivered into the stomach with an endoscope when such studies are required. 18 Intubation of the trachea or the esophagus may be complicated by the presence of a Zinker diverticulum. A large diverticulum displaces the lumen of the esophagus. The tip of the intubation instrument is often directed preferentially into the diverticulum. At endoscopy, it may be difficult to distinguish the lumen of the diverticulum from the true lumen of the esophagus. See Fig. 26.1a, endotracheal intubation, placement of a nasogastric tube, and intubation of the esophagus for upper endoscopy, endoscopic retrograde cholangiopancreatography, or transesophageal echocardiography may be difficult. Perforation can occur. Intubation of the esophagus in patients with Zinker diverticula should be performed under direct vision. When a large Zinker diverticulum causes marked anatomic distortion or when intubation with a side-viewing endoscope is required, direct intubation is not prudent. In such cases, a forward-viewing endoscope can be used to pass a soft-tipped guide wire into the esophageal lumen. 19 The guide wire is then backloaded into the endoscope, and the endoscope is advanced into the esophagus over the guide wire. An alternative technique consists of passing a forward-viewing endoscope loaded with an overtube. Once the endoscope has been passed into the esophagus, the overtube is advanced, the forward-viewing endoscope is withdrawn, and the side-viewing or ultrasound endoscope is passed through the overtube. 20 Treatment and prognosis. Patients with small asymptomatic or minimally symptomatic diverticula can be followed, because progressive enlargement is uncommon. 21,22 Patients with large and symptomatic Zinker diverticula should be offered treatment. 22,23 Zinker diverticula may be treated by open surgical procedures or by transoral endoscopic techniques using rigid or flexible endoscopes. Open surgery for Zinker diverticula is typically performed through the left neck in patients with large, greater than 5 cm, diverticula that extend into the thorax. 24 Young patients and patients with small diverticula may also be candidates for open surgery. 25 Large diverticula can be resected, inverted, or suspended, diverticulopexy. Cricopharyngeal myotomy is performed to treat the hypertonic cricopharyngeus muscle, and is the key aspect to treating this disorder. The hypertonic cricopharyngeus muscle must be divided to relieve distal obstruction. If diverticula are resected without myotomy, there is an increased risk of postoperative leaks and an increased frequency of recurrence. 25,26 Complications of open surgery include anastomotic leaks, mediastinitis, esophagocutaneous fistula, and vocal cord paralysis from injury to the recurrent laryngeal nerve, which runs in the tracheoesophageal groove. One review of 22 research studies including 1,793 patients who underwent open surgery for Zinker diverticulum found an initial success rate of 96%, a morbidity rate of 11%, a 5% perforation or leak rate, and a 3.5% symptom recurrence rate over a median of 36 months of follow-up. 23 Endoscopic treatment of Zinker diverticulum can be performed using a rigid endoscope or flexible endoscope, with division of the fibrotic septum between the esophagus and the diverticulum. 25,27 Compared with open surgical approaches, endoscopic approaches are associated with shorter anesthesia. AB Fig 26.1 Zinker diverticulum. A. Endoscopic view. It is often difficult to distinguish the lumen of the esophagus from the lumen of the diverticulum. B. Barium esophagogram showing a diverticulum large enough to cause esophageal obstruction when it fills. A. Courtesy of the late Dr. David Langdon. B. Courtesy Dr. Charles E. Pope, Seattle, W.A. Box 261 presenting symptoms in patients with a Zinker diverticulum aspiration choking dysphagia halitosis regurgitation voice changes weight loss 374 Part 4 topics involving multiple organs times, lower complication rates, and shorter hospital stays. Endoscopic techniques are suitable for patients with medium-sized diverticula, 2 to 5 cm. Rigid diverticuloscopes and flexible endoscopes have been used. The diverticuloscope provides visualization of the lumen of the esophagus and diverticulum and the septum between them, Fig 26.2. This septum is composed of the posterior wall of the esophagus and the anterior wall of the diverticulum and includes the UES. The muscular layers of this septum, and UES, are incised, restoring a single lumen. The incision can be performed by a number of techniques. With a rigid diverticuloscope, CO2 laser, surgical stapling, argon plasma coagulation, electrocautery, or harmonic scalpel can be used for the procedure. 22,25 During endoscopic stapling, one leg of the stapler is placed in the esophagus and the other into the diverticulum. The septum is then divided and stapled with 2 rows of staples on each side of the division line. The Zinker diverticulum must be at least 3 cm in length to be able to seat an adequate length of the stapler. Modifications of the stapler and other techniques may improve results in short diverticula. 28 Complications of endoscopic procedures include bleeding, perforation, and leaks, but these are uncommon if a stapler-assisted technique is used. In a review of rigid endoscopic treatment of Zinker diverticulum, combining 11 studies of 494 patients, the median initial success rate was 95%, with a 4% rate of conversion to open surgery, a 3% rate of major morbidity, with recurrence of symptoms in 5% over a median follow-up of 16 months. 23 Flexible endoscopic techniques also have a role in the treatment of Zinker diverticula because rigid diverticuloscopes cannot be used in patients who have limited neck extension or limited ability to open their mouth. 26 Transparent caps or a soft diverticuloscope may be attached to the endoscope to improve visualization. 2931 A variety of techniques can be used to perform the endoscopic myotomy, including needle knife, argon plasma coagulation, monopolar forceps, or harmonic scalpel. 22,29 Complications of flexible endoscopic techniques include cervical and mediastinal air dissection, which are common, as well as perforation and mediastinitis. In a review of 20 studies of flexible endoscopic treatment of 813 patients with Zinker diverticula, the initial success rate was 91%, with an 11% adverse event rate, and an 11% recurrence rate after a median of 23 months of follow-up. 32 Flexible endoscopic treatment of Zinker diverticula has typically been performed by surgeons, but some expert endoscopists have begun performing these procedures. Video 26.1.4 Diverticula of the esophageal body. Diverticula of the esophageal body are most commonly located in the middle or lower third of the esophagus, Fig 26.3. Epidemiology, etiology, and pathophysiology estimates of the frequency of esophageal body diverticula vary from a prevalence of 0.015% seen on autopsy to 2% in patients referred for radiologic evaluation of swallowing disorders. 33-34 These diverticula can be divided into 2 types, traction and pulsion diverticula. Traction diverticula are related to an inflammatory, fibrotic, or neoplastic process outside of the esophagus. Traction diverticula are often related to mediastinal inflammation associated with tuberculosis or histoplasmosis. 35 Enlarged mediastinal lymph nodes from lung malignancies can also lead to traction diverticula. Pulsion diverticula are typically caused by motility disorders. The most common type of pulsion diverticula is an epiphrenic diverticula, which is located near the diaphragmatic hiatus, Fig. 26.4. About 80% of epiphrenic diverticula are associated with esophageal motility disorders such as achalasia or distal esophageal spasm, which are discussed in Chapter 43. 36-37 Epiphrenic diverticula have been reported as a complication of band-based obesity surgery, due to obstruction of the esophagus and upper stomach by the band. See Chapter 8, 3839 Congenital bronchopulmonary foregut malformations can also present with esophageal diverticula. 40 Clinical features and diagnosis. Congenital and traction diverticula of the esophagus are usually asymptomatic, particularly when in the mid and lower esophagus. If symptoms are not present at diagnosis, they rarely occur during follow-up. When symptoms occur, the most common are dysphagia, food regurgitation, reflux, weight loss, and chest discomfort. 41 Dysphagia may be caused by an underlying motility disorder or by extrinsic compression of the esophagus by a large diverticulum, with preferential filling of the diverticulum. 3637, 42 Bronchopulmonary foregut fistulas can develop, however, leading to cough, pneumonia, and recurrent bronchopulmonary infections. 43 Diagnosis of epiphrenic diverticulum can be made during endoscopy or barium radiography. An epiphrenic diverticulum may be mistaken for a diaphragmatic hernia or duplication cyst on chest radiography. Endoscopy may show an empty diverticulum or the presence of food debris, Fig 26.5a. Diagnosis is best made by barium swallow, which serves to visualize the diverticulum and localizes it more precisely than endoscopy, see Fig 26.5b. The radiologist must be alerted to the possibility of this diagnosis, because oblique views will be required to demonstrate diverticuloscope. Esophageal lumen Zinker's diverticulum. Fig 26.2 Diverticuloscope. The instrument is positioned to expose the common wall between the lumen of the esophagus and the Zinker diverticulum. Fig 26.3 Endoscopic view of a midesophageal diverticulum. These diverticula are most apparent when the esophagus is well insufflated. Chapter 26 Diverticula of the pharynx, esophagus, stomach, and small intestine. 375 26 The diverticulum. CT should also be considered to ensure no associated pathologic adenopathy or mass lesions that might be causative of a pulsion diverticulum. Complications. Squamous cell carcinoma has been reported in epiphrenic diverticula. 44,45 As with Zinker diverticula, accumulation of radioactive iodine tracer in esophageal diverticula has been mistaken for metastatic thyroid cancer. 46 Bleeding from an ulcerated esophageal diverticulum has been reported. 47 Regurgitation and aspiration of the contents of the diverticulum may complicate induction of anesthesia. Perforation is possible during nasogastric intubation or UGI endoscopy treatment, and prognosis. Asymptomatic diverticula of the esophagus need no treatment. Only patients with symptoms clearly related to their diverticula should be treated. Preoperative endoscopy and manometry are advisable. It can be difficult to pass a manometry catheter beyond the diverticulum and into the stomach, but documentation of achalasia or distal esophageal spasm is helpful for guiding treatment. 48 Surgical treatment of esophageal diverticula can be performed by open, laparoscopic, combined laparoscopic, thoracoscopic, or robotic techniques. 49, 50 Epiphrenic diverticula are often amenable to a laparoscopic approach, which has the advantages of a shorter hospital stay and a quicker return to normal. Activities, see Fig 26.5c. Large diverticula may be inverted or resected. Given the high prevalence of associated motility disorders such as achalasia, esophageal myotomy is performed in most cases. 41, 49 Small diverticula can be treated by myotomy without resection. The advantage to foregoing the diverticulectomy is that there is no staple line to heal, decreasing the risk of a leak. It must be understood that the symptoms are usually related to the underlying motility disorder and not the diverticulum itself. Therefore, treating the underlying condition, usually with myotomy, is the key component of the surgery. To prevent gastroesophageal reflux after myotomy, a partial posterior, toupee, or anterior, door, fundoplication may be performed. 41, 49 The prognosis for patients who undergo surgery for esophageal diverticula is good, with rates of symptom improvement of 88.5%, with better symptom response rates when diverticulectomy is performed. 49 Esophageal intramural pseudodiverticula. Esophageal intramural pseudodiverticula, EIP, were first described in 1960. 51 The pseudodiverticula are flask-shaped outpouchings from the lumen of the esophagus, ranging in size from 1 to 4 mm. Epidemiology, etiology, and pathophysiology EIP are more common than the small number of published case reports would imply. EIP have been demonstrated in 0.09% to 0.15% of barium swallow studies. 52,53 patients are found to have EIP, most commonly in their 6th or 7th decades. The condition is slightly more common in men than in women. 54 EIP are abnormally dilated ducts of submucosal glands. They are thought to be acquired and are often associated with conditions that cause chronic esophageal inflammation. The ducts may become dilated because of periductal inflammation or fibrosis. 55 Esophageal strictures are commonly associated with EIP, but GERD, chronic candidiasis, caustic ingestion, esophageal cancer, and eosinophilic esophagitis are also associated with EIP. 52-54, 56, 57 Marked thickening of the esophageal wall has been noted in some cases by CT or EUS. 58, 59 Clinical features and diagnosis. EIP can be discovered on a barium swallow done for dysphagia or heartburn, Fig 26.6a. EIP may also be an incidental finding in patients without related symptoms. The esophageal pseudodiverticula are localized in most cases but are diffusely scattered throughout the esophagus in 40% of cases. 54 Strictures are common and tracking or communication between adjacent pseudodiverticula can also occur. 60, 61 The differential diagnosis on barium swallow examination includes esophageal ulceration. Although the endoscopic appearance of EIP is characteristic, see Fig. 26.6b. The openings of EIP are small and are often missed. EIP located within an area of stricture are particularly difficult to see at endoscopy. Symptoms, when present, are generally related to the associated condition, such as stricture or candidiasis, rather than to the EIP. Complications due to EIP are rare. Cancer must be excluded by upper endoscopy if a stricture is present. Increased rates of esophageal cancer have been found in patients with EIP. 52 There have been rare case reports of perforation of EIP leading to mediastinitis. 62, 63 Treatment and prognosis. Treatment of EIP should be directed at the underlying condition, such as stricture, acid reflux, or candidiasis. Dilation of the esophagus has been reported to provide symptomatic improvement of dysphagia in EIP. In one series of 22 patients with EIP, all had improvement in dysphagia symptoms with esophageal Fig. 26.4 barium esophagogram showing an epiphrenic diverticulum immediately above the stomach. In this projection, the diverticulum may be confused with a hiatal hernia. Courtesy Dr. Charles A. Rohrman and Dr. Charles E. Pope, Seattle, WA. 376 Part 4 Topics involving multiple organs. BAC Fig. 26.5 Giant esophageal diverticulum. A. Endoscopic view of a large esophageal diverticulum with food and liquid, arrows. B. Barium esophagogram showing a large esophageal diverticulum. C. Laparoscopic resection of a large diverticulum, arrows, of the esophagus, arrowheads. B and C. Courtesy Dr. Tai Pham, Dallas, TX. Fig. 26.6 Esophageal intramural pseudodiverticula. A. Barium esophagogram showing small outpouchings. B. Endoscopic view. Tiny openings of the pseudodiverticula are seen in this patient, who also has a distal esophageal peptic stricture. AB Chapter 26 Diverticula of the pharynx, esophagus, stomach, and small intestine 377 26 Bouginage, but multiple dilation sessions were often required. In addition, 57% required repeat dilation due to recurrence of dysphagia symptoms. 61 The EIP may persist even if treatment relieves symptoms. 54 Gastric diverticula are uncommon and are typically incidental findings identified during endoscopy or imaging studies. Epidemiology, etiology, and pathophysiology. Gastric diverticula are found in only 0.04% of UGI X-rays and 0.02% of autopsies. 64 Juxtacardiac diverticula make up 75% of all gastric diverticula. These are most often located near the gastroesophageal junction on the posterior aspect of the lesser curvature, Fig 26.7a, 0.65. They are most commonly found in middle-aged patients, although cases have been reported in children and adolescents. 0.66. They typically range in size from 1 to 3 cm in diameter but are occasionally larger. Intramural or partial gastric diverticula are formed by projection of the stomach mucosa through the muscularis. These diverticula are found most commonly on the greater curvature. 0.67,68. Deformities caused by peptic ulcers or other inflammatory processes can resemble prepyloric diverticula on barium studies or at endoscopy. See Fig 26.7b. Gastric diverticula have been reported as a complication of obesity surgery, particularly from vertical banded gastroplasty, although they have also been seen after Roux-en-Y gastric bypass. 0.69,70. Clinical features and diagnosis. Juxtacardiac diverticula are almost always asymptomatic. Rarely, patients may complain of pain or dyspepsia attributable to a diverticulum. During endoscopy, juxtacardiac diverticula are best seen on a retroflexed view. They may be missed on barium study unless lateral views are taken. On CT, they may appear as air or contrast-filled suprarenal masses and can be mistaken for an adrenal mass or cyst. 0.71. The structure can lead to a dilemma in diagnosis if it is fluid-filled alone. This can be mistaken for a pancreatic cystic lesion. The combination of air and fluid leads the radiologist to consider a pancreatic abscess in the differential. Intramural diverticula do not usually cause symptoms. They are often mistaken for ulcers on barium studies. Complications of gastric diverticula are rare. Cancer has rarely been reported. 0.72,73. Bleeding rarely occurs and may require combination therapy for hemostasis, such as hemoclips and epinephrine injection. 0.74,75. Perforation is also very rare. 0.75. Bleeding that cannot be controlled with endoscopic techniques may require referral for surgery. Treatment and prognosis. Intramural diverticula require no intervention. Juxtacardiac diverticula almost never require treatment. A clear association with a specific symptom complex should be firmly established before considering resection, because more common diagnoses, e.g., dyspepsia, reflux, can cause unexplained UGI symptoms. If a patient with a juxtacardiac diverticulum is referred for surgery, it may be prudent to place an endoscopic tattoo near the diverticulum, to assist with localization during surgery. Laparoscopic diverticulectomy can be used for simple resections for symptoms or perforation. 0.76. In these cases, the stomach is mobilized laparoscopic and the diverticulum is stapled, leaving the majority of the stomach intact. Proximal diverticula near the esophagogastric junction are handled with care to avoid narrowing this area with the stapler. Placement of a bougie can help avoid narrowing of the gastroesophageal junction. Duodenal diverticula. Duodenal diverticula can be extraluminal or intraluminal. Extraluminal diverticula. Epidemiology, etiology, and pathophysiology. Extraluminal duodenal diverticula are noted in about 5% of UGI X-rays and seen in roughly 20% to 30% of ERCP studies. 0.77,78. They are thought to be acquired and are typically seen in patients older than age 50. 0.78. They arise in an area of the duodenal wall where a vessel penetrates the muscularis or where the dorsal and ventral pancreas fuse in embryologic development. About 75% are located within 2 cm of the ampulla, on the medial wall of the duodenum, and are termed juxtapapillary diverticula, JPD, Fig 26.8a. AB Fig 26.7a, juxtacardiac gastric diverticulum. This wide-mouthed diverticulum, arrows, was seen on a retroflexed view of the cardia. The mucosa within the diverticulum was normal. B. Prepyloric gastric diverticulum. 378 Part 4 Topics involving multiple organs. Clinical features and diagnosis. Duodenal diverticula are sometimes diagnosed on UGI X-rays. They are easily missed on endoscopy unless a side-viewing endoscope is used. A duodenal diverticulum may be mistaken for a pancreatic pseudocyst, peripancreatic fluid collection, pancreatic abscess, cystic pancreatic tumor, hypermetabolic mass, or distal bile duct stone on various imaging modalities, ultrasonography, CT, MRI, or PET-CT. .79-83 If a diverticulum is suspected on CT or MRI, the diagnosis can be clarified by having the patient drink water and repeating the scan, or by using negative contrast agents during MRI. 84,85 Complications Although extraluminal duodenal diverticula are relatively common, complications are rare. Complications associated with extraluminal duodenal diverticula include perforation or diverticulitis, bleeding, acute pancreatitis, and bile duct stones. 77,86-88 Duodenal diverticulitis may present as a free or contained perforation. Patients present with pain in the upper abdomen, often radiating to the back, and may have signs and symptoms of sepsis. An abdominal CT scan may reveal thickening of the duodenum, retroperitoneal air, phlegmon, or abscess. Bleeding has been reported from Dolifoy-like lesions or ulcers within duodenal diverticula. 89,90 Bleeding from duodenal diverticula may be very difficult to diagnose, requiring examination with a side-viewing endoscope or angiography. In some patients, the site of bleeding is discovered only at the time of surgery. Patients with multiple duodenal diverticula may develop bacterial overgrowth and malabsorption, see Fig 26.8b, see chapters 104 and 105. 91 JPD have been associated with bile duct stones, cholangitis, SOD, see chapter 63, and recurrent pancreatitis, thought to be caused by an abnormal entrance of the pancreatic duct into the diverticulum. 77,92-95 Delayed emptying of the bile duct may occur, even after sphincterotomy. Stasis within diverticula can result in bacterial overgrowth, leading to bile salt deconjugation and increasing the risk of primary bile duct stones. 77,96 JPD do not appreciably increase the difficulty of cannulation or the risk of complications at ERCP performed by experienced therapeutic endoscopists. 78,97 Several techniques have been described to overcome difficulties associated with an ampulla situated deep within a diverticulum. 78,97 Treatment and prognosis. Extraluminal duodenal diverticula rarely require therapeutic intervention. Resection of duodenal diverticula should never be performed for vague abdominal complaints. Bleeding, diverticulitis, and perforation are the most common problems associated with duodenal diverticula. Endoscopic control of bleeding from diverticula has been accomplished using various techniques, including bipolar cautery, epinephrine injection, and hemoclips. 89,90,98 If the diagnosis is not made preoperatively, surgical control of bleeding can be accomplished through a duodenotomy. Many patients with duodenal perforation or diverticulitis undergo surgery for diagnosis and treatment, including drainage and resection of the involved diverticulum, if feasible. In resecting the diverticulum, the pancreatic duct and bile duct can be injured, leading to biliary and pancreatic duct leaks and pancreatitis. If the diagnosis of duodenal diverticulitis is made preoperatively, conservative therapy with percutaneous drainage and antibiotics is preferred. 88 Whipple procedure is a last resort and may be needed in the patient who has undergone inadvertent transection of the bile duct and pancreatic duct at time of diverticulectomy. Intraluminal diverticula. Epidemiology, etiology, and pathogenesis. Intraluminal duodenal diverticula are very rare. Most patients present between the ages of 30 and 60, with men and women equally affected. 99 Intraluminal duodenal diverticula, windsock diverticula, are single saccular structures that originate in the second portion of the duodenum. They are connected to the entire circumference or only to part of the wall of the duodenum and may project as far distally as the fourth part of the duodenum. AB Fig 26.8a, juxtapapillary diverticulum identified during ERCP, arrow. A sphincterodome is inserted into the nearby ampulla, arrowhead. B. Upper GI radiograph showing multiple large duodenal diverticula. A. Courtesy Dr. Zishan Ramzan, Dallas, TX. Chapter 26 Diverticula of the pharynx, esophagus, stomach, and small intestine. 379-26 There is often a second opening located eccentrically in the sac, Fig 26.9. Both sides of the diverticulum are lined by duodenal mucosa. During early fetal development, the duodenal lumen is occluded by proliferating epithelial cells and later recanalized, see Chapter 49. Abnormal recanalization may lead to a duodenal diaphragm or web. Over time, peristaltic stretching may transform the diaphragm into an intraluminal diverticulum. Clinical features and diagnosis: intraluminal diverticula are often asymptomatic but may become symptomatic at any age. The most common symptoms are those of incomplete duodenal obstruction, including nausea, vomiting, and abdominal pain. 99 The typical radiographic appearance is that of a barium-filled globular structure of variable length, originating in the second portion of the duodenum, with its fundus extending into the third portion and outlined by a thin radiolucent line. The CT appearance has been reported as a ring-like soft tissue density in the lumen of the second portion of the duodenum, outlined with oral contrast and containing oral contrast and a small amount of air. Halo sign, 100 at endoscopy. An intraluminal diverticulum is a sac-like structure with an eccentric aperture or a large, soft, polypoid mass. If the diverticulum is inverted or at 101,102 endoscopic diagnosis may be difficult. A long sac may be mistaken for the duodenal lumen, whereas an inverted diverticulum may be mistaken for a large polyp. Complications: obstruction may be precipitated by retention of vegetable material or foreign bodies within the diverticulum, which commonly include food and less commonly coins or marbles. 103-105 Pancreatitis and bleeding have also been reported. 92,101 Gastric retention or dilation of the duodenal bulb may result from chronic partial obstruction caused by the diverticulum. Treatment and prognosis: treatment may include resection in patients with symptoms of obstruction or bleeding, which can be performed laparoscopic. 99 Successful endoscopic resection of intraluminal duodenal diverticula has also been reported. 106 Jejunal diverticula in 1881, Sir William Osler wrote about a patient with jejunal diverticula who, for years, had suffered much from loud rumbling noises in his belly, particularly after each meal. So loud were they that it was his habit, shortly after eating, to go out and take a walk to keep away from people, as the noises could be heard at some distance. 107 Epidemiology, etiology, and pathophysiology: diverticula of the small bowel, apart from duodenal and mecal diverticula, are most commonly found in the proximal jejunum and are seen in approximately 1% of the population. 108 About 80% of jejunoileal diverticula arise in the jejunum, 15% in the ileum, and 5% in both. Small bowel diverticula have been found in about 0.5% to 5% of small bowel X-rays and autopsies. 109,110 They are commonly multiple and can vary from a few millimeters to several centimeters in size. They are usually located on the mesenteric border of the small bowel. Small bowel diverticula generally lack a true muscular wall and are considered as acquired. The cause of jejunoileal diverticula is largely unknown. Many patients have an underlying intestinal motility disorder. Periodically elevated intraluminal pressures can lead to herniation through areas of weakness at the mesenteric border where blood vessels penetrate the muscularis. Visceral neuropathies and myopathies, including progressive systemic sclerosis, can lead to chronic atrophy and fibrosis of the intestinal wall, with resultant herniation and diverticula formation. See Chapter 37. 111 Clinical features and diagnosis: jejunal diverticula are best diagnosed by UGI radiography with small bowel follow-through or CT with oral contrast and can also be identified on small bowel enteroscopy and video capsule endoscopy. 112-115 Jejunal diverticula most commonly occur on the mesenteric border of the bowel, in contrast to mecal diverticula, which occur on the anti-mesenteric border. Many cases of jejunoileal diverticulosis are asymptomatic or associated with nonspecific symptoms for which patients may not seek medical attention. About 40% of cases are discovered incidentally. 110 Various symptoms and clinical problems may occur with jejunal diverticula. The most common clinical features are recurrent abdominal pain, early satiety, and bloating. Loud borborygmi and intermittent diarrhea may occur, symptoms which may be caused by an underlying motility disorder. 116 Complications similar to diverticula of the colon. Complications of jejunal diverticula include bleeding, diverticulitis, and perforation. Bleeding jejunal diverticula have been treated during double balloon enteroscopy, although there is some risk of perforation. 117-119 malabsorption may result from associated small bowel bacterial Fig 26.9 intramural duodenal diverticulum, Windsock diverticulum. A. Diverticulum attached to entire duodenal circumference. B. Diverticulum attached to only part of the duodenal circumference. Ampulla of Fata AB 380 Part 4 Topics involving multiple organs overgrowth, see chapters 104 and 105. 110-120 Patients with jejunal diverticulosis and severe dysmotility can develop intestinal pseudoobstruction, see chapter 124. Patients with intestinal pseudoobstruction may periodically have small amounts of free intraperitoneal air, pneumoperitoneum, without overt perforation. 121 If such patients are otherwise well, they should be carefully observed. Surgical intervention is often not necessary. Bleeding from small bowel diverticula may be difficult to localize. 117-122 If a source of bleeding is discovered in the small bowel at angiography, it may be useful to leave a small catheter within the feeding vessel as the patient is taken to the operating room. When the patient is explored, a small amount of dye can be injected through the catheter, staining the involved bowel. This may help the surgeon localize an otherwise obscure lesion. Diverticulitis may result in free perforation or an abscess contained within the mesentery. 123 The finding of an inflammatory mass in the mesentery should raise the possibility of a perforated small bowel diverticulum. 124 Because jejunal diverticula usually project into the mesentery, they can be difficult to detect, even at surgery. Large enteroliths can form in jejunal diverticula and lead to mucosal erosion, with bleeding, diverticulitis, perforation, or intestinal obstruction. 123-125-126 Jejunal diverticulosis has also been associated with small bowel volvulus. 127 Treatment and prognosis in patients with small bowel diverticulosis and suspected dysmotility. The use of oral antibiotics to treat associated bacterial overgrowth may lead to improvement in bloating and diarrhea, as well as malabsorption. See chapters 104 and 105. 128 In patients with bleeding, perforation, or diverticulitis, a limited surgical resection of the affected section of the bowel should be performed, but this may be difficult to localize with precision. 123-129 In patients with symptoms of chronic intestinal pseudoobstruction, surgery should generally be avoided, although carefully selected patients may benefit. 130 If a long segment of bowel is resected in an attempt to remove all the diverticula, the patient may be left with short bowel syndrome, which can lead to severe disability. See chapter 106.